Rafal Dziadziuszko. I'm thoracic clinical oncologist from the Medical University of Gdańsk in Poland, where I chair the Department of Oncology and Radiotherapy and Early Phase Clinical Trials Unit. I'm pleased to report to you the data that I have reported at WCLC this year, namely the data on mesothelioma and on small cell lung cancer. So mesothelioma was covered very nicely this year. We have seen the molecular and histopathological classification of 3 large data sets that were included in the TNM classification of mesothelioma. That gave us the current knowledge of outcomes of these patients who are stratified by different molecular aberrations, namely BAP1 loss, NF2 mutations, P53 mutations, and others. Interestingly, BAP1 loss was prognostic in this large data set that included more than 250 patients, both by genomic evaluation, but also by immunohistochemistry. The other aberrations, namely NF2, P53, not surprisingly, and others, were poor prognostics. That means patients who harbored these aberrations had worse outcomes. The second study that was summarized nicely was a phase 3 study that added pembrolizumab to 4 to 6 cycles of chemotherapy with carboplatin and pemetrexed. The study was associated with superior outcome in pembro group of patients, and this benefit was mainly driven by patients who harbored non-epithelioid histology. And this is in line with other observations in mesothelioma. The median overall survival was 17 months in experimental versus 16 months in control group in overall population of patients. Interestingly here, BAP1 loss was again seen as a positive prognostic factor, but not predictive for benefit of pembro. MTAP loss, which was also evaluated in this study, was negative prognostic factor and was not predictive of the benefit from addition of pembrolizumab. So the next study that I want to summarize is a study in a selected group of patients who qualify for surgery in specialized centers. In a network of US and Canadian institutions, the study included 2 groups of patients that received either nivolumab monotherapy or nivolumab and ipilimumab treatment for 3 cycles, and then were operated, and then followed by post-surgical treatment, either chemotherapy or radiation, followed by immunotherapy. Patients who received nivolumab had a median overall survival of roughly 9 months and overall survival of 19 months. Patients who received nivo-ipi had median PFS of 19 months and overall survival of 28 months. So this group of patients, we can say that the outcomes are promising, although early data do not really provide us with much evidence whether we can use neoadjuvant treatment in real practice. The small cell lung cancer data that I want to summarize is the phase 1b study with tarlatamab plus either atezolizumab or durvalumab maintenance in the setting of patients who received 4 to 6 cycles of chemoimmunotherapy with either atezo or durva and platinum etoposide combination. In this trial, which is a phase 1b study, combination of tarla plus PD-L1 inhibitors was safe, as shown with only few CRS and ICANS toxicity issues and no dose-limiting toxicities. Very encouraging overall survival data were shown, with 12-month overall survival counted from the start of treatment as over 80%, which is typically 12 months overall survival is a typical survival of patients treated upfront with chemoimmunotherapy. So now the study is proceeding to the first-line treatment, and another study with tarlatamab, given concomitantly with chemoimmunotherapy, is also taking off to show us whether the addition of this DLL3 targeting agent will change the fate of small cell lung cancer patients. I'm responsible for overseeing patients in our phase 1 program in the Medical University of Gdańsk, where we have a number of different molecules now currently tested. I'm quite interested to see also the efficacy of other DLL3 inhibitors, out of which obrixtamig has very promising phase 1 data. The other new wave of systemic therapies for lung cancer, both small cell and non-small cell, seems to be bispecific antibodies covering VEGF and either PD-1 or PD-L1 targets. And we have a number of these molecules also in our programs, with hopes that they will be next to come for systemic therapies of both non-small cell and small cell lung cancer.